Thank you so much. Good afternoon, good evening, one and all. Very, very happy to be having you all as delegates today to start on the webinar, Balancing the Sweetness, the webinar on gestational diabetes management. And at the outset, let me welcome the convener of this webinar, the person who is a candidate for FOGSI Medical Education Committee 2025, Dr. Vijaya Ma'am, our own Dr. Vijaya Ma'am, who has been the president of OGSI in 2024-25. She's a former director, IOG, Madras Medical College from 2019 to 22. She's a former director of Institute of Social Obstetrics and Gynecology in MMC 2013 to 19. She has been a member of FOGSI and OGSI Medical Education Committee. With a vast experience of teaching of about 30 years, she's been the faculty for UG and PG revision courses. She's secured the state-level Master Trainer Awards, and she's a FOGSI Master Trainer in HPV. She has played a key role in the Lakshya certificate, and she has conducted Aksharam webinar series, which is very famous among people. We welcome you, madam, to start the webinar with a prayer song and the lighting of Kuthuvelakku.
Thank
Vijaya
you,
ma'am,
for
please.
the introduction. Yeah, we will go to the prayer song. Yeah, we can light the Kuthuvelakku now. Sir, join பண்ணிடுங்க sir. Okay, so start out the sir. Thank you, sir. I have a Madhumita is my very dear friend, and I can say my student, and she's a very enthusiastic. I just told her we will do some webinars, and then immediately she said, "Madam, whatever you say, I will do." And most of the things are curated by her, the topics and everything. And you all know she's a fertility physician, and you must have heard her in almost all the infertility conferences and CME. And she's a clinical director and senior fertility physician, Nova IVF Fertility. And she has lots of awards in OGSI, RCOG, ACOG, Get Endo, UISR, Youth Icon Award of 2023, and Best Paper in COGS 2024, and lots of publications in BJOG and IJCP. And she has a special interest on biological hair for poor ovarian and sperm reserve patients, and also in oncofertility. I render my heartfelt thanks to Madhumita for being so helping to me and making this thing happen. I'm very grateful to her, and a lot of good people have joined in. I'm so happy about that, Madhu.
Thank you, ma'am. Thank you, ma'am. So,
can-
ma'am, can I request you to introduce the expert panel for today? We have
Yeah.
two good expert panel with us. One is Dr. Sesha Sai sir, and we have our own Dr. Anjalakshi ma'am, both of them being the expert for both the sessions today. Please do introduce them, ma'am.
I think sir will be joining very shortly. You all must be knowing Sesha Sai sir. If you are in the WhatsApp group of examiners OG group, if you are not there, please tell me. I'll make you join in that group. Anything on any topic PPT you want, he will send you. You don't have to worry. And he all know he's worked in army as a captain, so he's very meticulous in maintaining the group, because there should not be any other talk other than academics in that group. And NSS program officer in Tirupati, and he is now the professor at Apollo Medical College Tirupati, and he's a Lions Club member and family planning commissioner, and hobbies are teaching, driving and technical analysis, and more than that, maintaining our own examiners OBG WhatsApp group. So welcome you, sir. You'll be joining us shortly. Our next expert, Madam is very dear to us. Anything in GDM, Madam, I will remember Madam. She has done lots and lots of work on GDM. You can see her CV because she has got a PhD in GDM under Tamil Nadu MGR Medical University, and she's a founder president of TNFOG, which is a very strong society of Tamil Nadu, and he's a SDI member, and she has given Dipsy Oration in 2017 and Gunasundari Oration in 2022. She got Best Doctor Award from IMA twice, Lifetime Achievement Award from Tamil Nadu government and from Dipsy, and she received Damodaran Award for Medical Services by IMA in 2022 and State Level Award for during Doctors' Day celebration in 2023, and she has got organized a critical care in
enough, Vijaya.
Yeah.
Enough.
Madam.
Thank you, ma. Thank you for the kind introduction. Thank you.
She's a PhD guide, and she is an examiner for UG, PG, and she's got lot of publications in Index Journal. So whoever wants to do any studies on GDM, Madam is always there to help you. Please contact her. I will give Madam's number to all of you. Shesi Sai, sir. Sir, we are not able to see you. Switch on your video, sir. Sir, welcome, sir. So nice of you to have agreed, and immediately.
Thank you, madam.
You've just now come from your college, just now got home, but still you are so supportive because we are doing a webinar. So nice of you, sir. So be there and give your expert comments, sir. Thank you, sir.
Thank you, ma'am.
Madhu, shall we go to the proposition?
Yes, ma'am. Yes, ma'am. So, having introduced the two experts, Dr. Anjalakshi ma'am and Dr. Sesha Sai sir, now we are going into the first session. Session 1 is going to be a talk on how GDM, the fetal-maternal complications could be prevented. And to start this, can we introduce our chairpersons, Dr. Kochumani ma'am, Dr. Somalata ma'am, and Dr. Pratibha ma'am. Dr. Vijaya ma'am, can you please do the honors of introducing them, please, ma'am?
Aditi?
Can you share the slide, please?
Sagiti? Ma'am is joined, Kuchumani ma'am. Mumtaz is there.
Yes, ma'am.
Can you please go ahead with the PPT of
Sure.
introduction, please? Dr. Kochumani ma'ams. Yeah, we'll be starting this session, and can we have the slides, please?
Yeah. Kuchumani ma'am is a gynecologist and an obstetrician and an infertility specialist, IVF specialist, and she specializes mainly in fertility medicine and minimally invasive gynec surgeries, reproductive endocrinology and infertility. And she has got special interest on reproductive endocrinology and infertility. And she has an important emphasis on health screening and preventive medicine in Malappuram and Kerala. And she's a president of Perindalmalla Society of Obstetric Gynecology. Welcome, ma'am.
Next slide, please.
Yeah, next is I didn't see her. Somalata. Yeah, Somalata, very sweet. The first one I called Somalata. Immediately she said, yes, ma'am, I'll come like that. So she's got her MBBS from Guntur and MS OBG from Pune. And she has a credential as an IMS menopause practitioner and special interest in endoscopy and high risk pregnancy. She's a secretary of Vijayawada Obstetrics and Gynec Society, and she's got the best poster in Yuva Foxy 2018, and she was a speaker in 2021 Yuva and Foxy VP Conference 2024 and South Zone Indian Menopausal Society Conference at Vijayawada. She has been a panelist in lots and lots of conferences, mainly Yuva Foxy. She's very young. Welcome, Somalata, for this.
Thank you, madam. Thank you so much for your kind introduction.
Pratibha. Pratibha is a consultant in assisted reproduction, a gynae laparoscopic surgeon, and also she is a high-risk pregnancy obstetrician at Makija Test Tube Baby Center in Maternity Hospital in Bilaspur. And she is currently the secretary of Bilaspur Obstetric and Gynec Society. Pratibha, welcome to this webinar, Pratibha.
Thank you, madam. Thank you so much.
Yeah. Ma'am, shall we start? Matangi? Madhupriya, please introduce Matangi.
Sure, ma'am. So a good friend, Dr. Matangi Rajagopalan, madam, a consultant in OBGYN Birthright by Rainbow Hospital at Gindi, Chennai. She's a member of ATN RCOG, member of IMA, OXY, and ISOPAC, an executive committee member of ATN RCOG. She's been known to us as an MRCOG Part 3 examiner, has done various presentations in conferences which are both regional and international, with special interest in areas of maternal medicine, high-risk pregnancy and recurrent pregnancy loss that she's been practicing, and with advanced labor ward management, teaching and training. Here we have Dr. Matangi Rajagopalan to present to us on the GDM, Preventing Materno-Fetal Complications. Welcome you, Dr. Matangi, ma'am.
Thank you, Madhu. Thank you for the kind introduction. You're able to see the screen?
Not
Not
yet.
yet.
Yes, ma'am. Yes.
Make it slideshow.
So first of all, I thank Vijaya Madam and Dr. Madhu for providing me this opportunity. Madam was my mentor during my PG days, and it gives me immense pleasure to present such a topic in front of doyens like Anjalakshi Madam, who has done a great work in GDM. So my topic today is update on GDM. I know it's a little difficult to finish in 15 minutes, but I will try to finish within 15 minutes.
Slideshow, make it slideshow.
Yes, ma'am. Yes. So we are going to concentrate on what are all the recent updates, which we can follow to prevent the fetal-maternal complications. The topic of today is, nicely curated, balancing the sweetness in pregnancy. I was, very much attracted because it reminds me of a proverb from Theodore Levitt. Anything in excess is a poison. Even sweetness in excess can be a poison. So that's what we are seeing in sweet pregnancies if it is uncontrolled can even have a bitter outcome rather than a sweet outcome. So our aim as obstetricians is to provide a sweet outcome for these women, even though they have diabetes in pregnancy. So what are all the common fetal complications we encounter? If you see classification of trimester wise, in the first and second trimester, we see a lot of increased risk of miscarriages, and also the risk of congenital anomalies are extremely high in diabetic mothers compared to the general population. In the third trimester, we have increased risk of unexplained IUDs in the third trimester, and these babies are notorious for becoming macrosomic due to uncontrolled sugars. And after delivery, if you look, the common complications are birth injuries for the baby because they are big and difficult deliveries, and the neonate can have hypoglycemia, hyperbilirubinemia, and we also need to be aware of hypocalcemia and magnesemia. And also these babies are at higher risk of developing respiratory distress syndrome, even if they are delivered at term, and have an increased risk of NICU admissions. And not but not the least, these babies also have a long-term risk of developing obesity, hypertension, and type 2 diabetes. So coming to maternal complications, we all know that these women have a higher risk of preeclampsia, and because of the association of polyhydramnios, they are also at risk of going into preterm labor. And also when it is uncontrolled diabetes, we are forced to do an iatrogenic preterm delivery in order to avoid major complications. Second thing is, if the mother is already having a pre-gestational diabetes and she's having an end organ involvement, we need to be aware that there can be a worsening of retinopathy or nephropathy during the pregnancy, and we have to take steps to prevent that. And these women, again, because of the forced thing, have an increased risk of ending up in cesarean section. And even if they deliver vaginally, there is a higher risk of having perineal traumas. So, what are all the pillars for prevention of these fetal-maternal complications? I explained. There are 6 pillars which we need to concentrate on. One, the key thing is the pre-pregnancy counseling. Second thing is an effective screening that will allow us to do an early diagnosis and intervention to avoid the complication. Once we have made the diagnosis, we should go for a targeted treatment so that we are within the goals of therapy of maintaining euglycemia. And how are we going to do the surveillance for the mother and fetus to avoid the complications? And the most important thing is the timing and mode of delivery to avoid birth injuries. Finally, the cherry on the cake is education and awareness of not only the women, but also the family and the society to avoid these complications. So let's look one by one. First is pre-pregnancy counseling. So when you take about pre-pregnancy counseling, we should be aware of the general counseling we make. The folic acid supplementation comes of immense importance in these women. Normally, we advise 400 to 800 micrograms. And age-old teaching is that these women require a higher dose of folic acid, which is 5 milligrams per day. For these women, assessment of maternal weight is extremely important, because in pre-pregnancy counseling, if you assess the weight and if they are obese, institution of lifestyle modifications can reduce their chance of having gestational diabetes in pregnancy. And even if they are pre-diabetic, it will reduce the complications that can happen during the pregnancy. So this is an important part when you go for pre-pregnancy counseling. Even if the mother takes a few months to achieve 5% weight reduction, then that will have a greater implication on the outcome of the pregnancy. So when you are seeing a normal mother, you should assess what are all the risk factors for her to develop the gestational diabetes. So think about obesity. If in previous pregnancy she had a big baby, if she had additional excess weight gain, or if there is a short interval from her previous pregnancy, or if there is an insulin requirement in her previous pregnancy, or the gestational diabetes was early onset, these women are at higher risk for recurrence of gestational diabetes in the current pregnancy. So these things have to be addressed. Now coming to the other medical conditions, we all know that thyroid and diabetes always go hand in hand because they are endocrinological. So we need to assess the thyroid status and the glycemic status, whether they are fit for undergoing a pregnancy, and vaccination routinely as we check for immune status for rubella. Coming to the specific for diabetes complicating pregnancy, women who are already diabetic, the most important thing is the assessment of HbA1c. So we all have a lot of evidence to say higher the HbA1c, the adverse outcomes are going to be more. So we have to advise the women that she should plan a pregnancy only when the HbA1c is less than 6.5%. Now coming to the pathis which we talked about, that is the retinopathy, nephropathy and the heart conditions. All these women require a fundus examination. If it's not been done in the last 3 to 6 months, the first time you see them, you have to do a fundus examination to assess the retinopathy changes, a basic ECG and echo to assess her heart condition. And for assessing the nephropathy, we always measure creatinine, albumin creatinine ratio and the total protein excretion, because all these are an indication of how much the kidney has been already damaged. Now coming to the most important point, most of these diabetic mothers are already hypertensive and they may be on already antihypertensives, or other oral hypoglycemic agents. So a review of prescription. This is very important for the PGs. Whenever you see a woman for the first time, look through the prescription. If they are on oral hypoglycemic agents, which is not suitable in pregnancy, you have to switch them over to insulin pre-pregnancy so that they can continue it during pregnancy. If they are on AC inhibitors, we all know that it can induce renal complications in the baby. So this has to be stopped and switched over to a suitable antihypertensives, and all lipid lowering agents, especially statins, should be stopped prior to the pregnancy. And these women should be asked to continue their surveillance until they become pregnant. Now, what are all the advantages? We've been talking about pre-pregnancy counseling. We have enough and above evidence to say that when you do an adequate pre-pregnancy counseling, it will reduce the HbA1c, it will reduce the risk of congenital abnormalities in the baby, and it reduces most of the fetal complications like preterm delivery, perinatal mortality, reduction in the SGA infants, and the reduction in the NIC admission. There was an interesting study done by Furman, which concluded that when you have a good preconceptional counseling, the incidence of congenital malformations was only 0.8%, whereas the incidence rose up to nearly 7.5 to 8% if you start the strict metabolic control after 8 weeks. So that is a 10% difference in the incidence of congenital malformations. So we should give more concentration on pre-pregnancy counseling. So we all know about these congenital malformations. I don't need to go. And the cutoff is usually less than 8.5. The incidence rate of anomalies 3.4%, whereas it goes above 8.5, the rate can be as high as 22. And NICE guidelines even recommends if the HbA1c is 10% to offer termination of pregnancy to avoid the high risk. Now, screening for gestational diabetes. Last 2 decades have been a roller coaster for screening of diabetes. Various governing bodies have given us various tests and various cutoffs to diagnose. Finally, we have come to a conclusion that what is working for our country, because in European countries, they do only high-risk screening. And in them, high-risk factor is ethnic origin of Asian origin or Indian origin. So in which way we come under a high-risk category, we as Indians. So we have now come to the conclusion agreed by many of the governing bodies that one nation, one test which works for us, which is the DIPSI test, and universal screening is recommended for all our women. So what is the DIPSI test? We give 75 grams of oral glucose to a woman, irrespective of her fasting status, irrespective of her last meal status, and then we measure a 2-hour post 75 grams test. Now, this test is very popular because it is very feasible, cost effective. You don't need to, make the mother fast, pregnant mother fast. So you have all the advantages. So what are all the criteria to diagnose? If the 2-hour level is more than 140 milligrams per deciliter, then it is diagnostic of gestational diabetes. If the 2-hour is more than 200, then we are thinking about somebody who's already a pre-gestational diabetes. But there is also a category which also requires important follow-up, is the third category, whose value is between 120 to 139 milligrams. This is called gestational glucose intolerance, because these women can slip into GDM in later gestation. So a screening test should always be able to pick up the most high-risk group. So when are we going to perform this test? Now, the age-old teaching was to do the test at 24 to 28 weeks initially, because I will come to the reasons why we were doing. But now the stress is on doing it at the first visit, which is at 8 to 10 weeks when we encounter the women for the first time. If that test is normal, then we again repeat the test at 24 to 28 weeks and again at 32 to 34 weeks. So these norms have been approved by quite a lot of governing bodies, including FOGSI, WHO, American Physician Associations of India, and FIGO, and others. So I think we should follow a uniform pattern so that we all stand on the same page. Now, coming to the facts behind the screening, how to come to this conclusion? Now, if you only did risk-based screening, we were able to find out only 1.4% of women as a gestational diabetes. Whereas by implementing universal screening, it showed around 2.7% incidence in the same population. So you will understand that if we do a risk-based screening, we'll be missing almost half of the gestational diabetes. So universal screening is mandatory. I spoke to you about the routine screening, which we did at 24 to 28 weeks, is because normally insulin resistance starts developing during the second trimester because of the placental hormones playing a major role in increasing the insulin resistance. And also performing the test too late also, there will be no step or window for us to do the interventions. So these were the reasons initially we did 24 to 28. But why now the stress on early screening? One is, if you don't screen early, you will be missing the unrecognized type 2 diabetes, which will be entirely missed until the second trimester. Second most important thing is the fetal pancreas starts secreting insulin as early as 9 weeks. And then in response to the maternal hyperglycemia, we are seeing that the fetal pancreatic cell mass becomes more and the secretion becomes more by the 16th week. So this priming of the fetal beta cells persists throughout the pregnancy, and that is the reason for accelerated fetal growth. So if you want to avoid the accelerated fetal growth, we have to avoid the initial trimester hyperglycemia. Now, this is the background for us to switching over to early trimester screening. Now, why the cutoff? This is not a magic number, 140 milligrams. Where did we get this number from? There are quite a few evidences which shows that not only the short term, but also the long-term morbidity in the offspring was very high when the cutoff point was more than 140 milligrams. So when they measured the birth weight and the serum peptide, it was more than the 90th centile at the cutoff point of more than 140. And also children born to mothers who had a third trimester plasma glucose more than 140 had a risk of 30% becoming a type 2 diabetic. And this macrosomia or permanent diabetic, it is not at an isolated cutoff point. It was a continuum starting from 120. That is the reason I told you the group who had 120 to 139 also need to be followed up, because these women can also have complications later in gestation. There are also other screening methods you might have heard about. After the HAPO study, we have the IADPSG criteria, where we usually take the cutoff as fasting 92, 1 hour 180, and 2 hour 153. And NICE guidelines have their own cutoff. But I think we should follow what suits our country according to the prevalence. I think DIPSI test makes wonders because it's much easier and easy to implement. Now, coming to the targeted treatment, which is the third pillar, we always start with a medical nutritional therapy and we follow it up for a few days. And then if that fails, we switch over to the pharmacotherapy, which includes metformin as well as insulin. So what do we mean by medical nutritional therapy? If a mother is diagnosed with gestational diabetes in the first or second trimester, we start the nutritional therapy for 2 weeks. If you're diagnosing in the third trimester, then we don't have much time. So we can only try the medical nutritional therapy for 1 week. If after this stipulated time, if the mother is not able to achieve the target sugar levels, which is fasting less than 95 and 2 hour less than 120, or if you're going to check 1 hour less than 140, then you have to add pharmacotherapy. Now, how do you do the nutritional therapy? Its assessment is based on what is the BMI of the mother and what is her physical activity. We always need to involve the dietitian in curating them a meal plan when they are on nutritional therapy. Now, a basic idea about what we give in meal plan is the carbohydrates should be 35 to 45% of the total calories, and it must be split between 3 meals and 3 snacks. We always ask the mother to prefer complex carbohydrates with a low glycemic index rather than going for a simple carbohydrates which will cause a high rise in the sugar. Coming to protein, they have a protein requirement of 1.5 grams per kilograms per day. And coming to the fat contribution, saturated fat should be less than 10% of the total calories. All the snacks should be a low fat snack, like, something boiled or steamed, and using lean meat instead of, normal red meat. And a high fiber content also will help them to control their sugars. We always advise these women to avoid paleo or keto diets during pregnancy because these can enhance lipolysis and increase the insulin resistance. So if medical nutritional therapy doesn't work, then the next drug is metformin. Metformin is recommended by DIPSI, NICE, and other governing bodies. Of course, metformin is not the first drug of choice, but it is useful in women who are obese and who have insulin resistance. So usually we start with a dose of 500 milligram once a day. It can be increased to twice a day to a maximum dose of 2 grams per day. We need to remember that metformin do cross the placenta, but the usage of metformin is, it is convenient. When you talk to the women about insulin, they always panic. Doctor, every day we have to take the injection. So in those women who are really stubborn and not ready to go to the insulin, this may be an option where it is less expensive, you require less monitoring, and you get a better compliance. Sometimes women who are obese with insulin resistance, it can be used as a complementary to insulin as well. Now, the advantage is you have less neonatal hypoglycemia when you are treating with metformin, but eventually 25 to 50% of these mothers will go on to require insulin. Now, when coming to the disadvantages, some studies have shown that the mothers who were on metformin, there was a doubling incidence of small for gestational age, and metformin is not suitable in women who already have vascular complications. For example, if they have preeclampsia or hypertension, or if the baby is already FGR, those mothers should not be prescribed metformin. The third wonder drug is our insulin. It is the drug of choice. We all know that insulin does not cross the placenta. We always usually pair a rapid-acting insulin with an intermediate or a long-acting insulin. Usually we have Aspartar Lispro, which is the rapid-acting insulin, and we have the NPH, which is the intermediate or the long-acting insulin. Nowadays, we have a lot of combinations like Novomix or Vixstart, which has prefixed combinations of short-acting as well as a long-acting insulins. Now, when the mother is already having complications in the pregnancy, like macrosomia or polyhydramnios or fetal growth restriction, your first line of treatment should be insulin rather than treating with metformin. The general requirement, we say that the insulin requirement increases from 0.8 through 1.2 from the first to the third trimester. So how do we give the dosage of insulin? Usually it is titrated according to the glycemic trends. Now 2/3 of the total dose is usually given in the morning and 1/3 is given in the night. And usually the dose of intermediate and short-acting insulin are in the range of 2:1 in the morning and 1:1 in the evening. Now, this is just, I'm not going to entirely read the slide. These are some of the safe insulins which we can use, and a knowledge of these will help us to educate the mother when to administer insulin based on their peak effect. Now, what is the monitoring principle when they are on treatment? We all know that in normal pregnancy, the physiology is these mothers have a low fasting levels because there is an insulin independent intake of glucose by the fetus and the placenta, but there is a mild postprandial hyperglycemia because of the diabetogenic placental hormones. So it will be reasonable for us to monitor fasting and postprandial for a mother who are already having diabetes. Now, we also do preprandial testing in some women, like pre-meal testing, when we want to adjust the rapid-acting insulin dose. Otherwise, the general recommendation is to monitor regular fasting and postprandial. We also, if they are on insulin, self-blood glucose monitoring is recommended. Now, recently we had an American Diabetes Association publishing their recent guidelines, standard of care in 2025, which agrees with the target levels. Women, gestational diabetic mother who are not treated with insulin, as I already told, the target level of fasting less than 95, 1 hour less than 140, and 2 hours less than 120. Even though the targets are same for GDM mothers with insulin, when the women are on insulin, we have to give a leeway because we want to avoid hypoglycemia, because these women can have hypoglycemia unaware during pregnancy. So we should give a leeway of therapeutic targets, avoiding hypoglycemia in women when they are on insulin. Now, what is the role of HbA1c monitoring? Now, HAPO study clearly told that if the HbA1c was increasing the levels, it is associated with adverse outcomes. and the adverse outcomes are lowest when the level is between 6 to 6.5. Now, what is the disadvantage with HbA1c? Pregnancy itself has a physiological increase in the red cell turnover. So normally itself we see a fall of HbA1c during pregnancy. So it may not be a reliable measure of your glycemic status. So we shouldn't rely just on HbA1c for measuring. And also it is an integrated measure. It does not tell you what is the actual postprandial level of hyperglycemia so that you can adjust the dose of insulin according to the HbA1c. But the one advantage is if a mother has less than 6% HbA1c in the second and third trimester, it tells us that she is at very low risk for macrosomia. Now, who are the thing we target? Continuous glucose monitoring pregnancy. It is not for all of the women. There was a concept trial which was published, which is a randomized control trial, where they combined the real-time continuous monitoring in addition to the standard of care. And they showed that even though there was only a mild improvement in HbA1c, there was a significant improvement in the sugar levels without increase in hypoglycemia. So these kind of monitoring is mainly for mothers who are type 1 insulin dependent diabetic, with treating them with significant risk of hypoglycemia. Only for those mothers, when we do continuous monitoring, we'll be able to give a better control without inducing hypoglycemia. Now, what is the disadvantage when we do continuous monitoring? It will not provide you data on fasting or postprandial hyperglycemia, so that, again, we can adjust the dose. And we clearly know that continuous glucose monitoring is not for women with type 2 diabetes or gestational diabetes. So just to give a sample of how a continuous glucose monitoring report looks like is this. The green zone, as you can see, is the time in range where you want the sugar control. So that must be, the goal is more than 70% should be in that region. And the amber and the brown region are high zones, that is time above range where it is more than 140. The goal must be less than 25%. And you have the red zone where it is time below range. The goal must be, which is the hypoglycemia zone, the goal must be less than 4, and severe hypoglycemia must be less than 1%. That's how you interpret a continuous glucose monitoring report. Now, coming to the surveillance, how are we going to follow up these fetuses? Now, when it comes to surveillance, we all need to do a uterine artery Dopplers in the first trimester to assess which of these babies will have vascular complications of fetal growth restriction. Second thing, as we all aware that there is a higher risk of fetal anomalies, anomaly scan at 18 to 20 weeks, followed by a fetal echo to look at the heart and the vessels at 20 to 24 weeks is imperative. And these mothers, because of the problems in growth, we need to do growth scans and Doppler starting from 28 weeks every 4 weeks. Now, the most important parameter that will give us a clue for macrosomia or fetal growth restriction is your abdominal circumference. And Dopplers are mainly useful when they have preeclampsia or fetal growth restriction. Because of this,
Few more minutes.
madam?
Few more minutes.
Okay, ma'am. So because of the increased risk of intrauterine demise, these mothers should be put on non-stress test and biophysical profile from 36 weeks onwards. When they are GDM well controlled, you don't need to do this extra monitoring. When it comes to maternal surveillance, most of it we have already covered. It is usually a multidisciplinary visit with an obstetrician, fetal medicine, diabetologist, screening for end organ involvement, which we have already discussed. These women are at increased risk of infection. So, screening for UTI and vaginal candidiasis is very, very important in this mother. And aspirin 150 milligram should be prescribed in all diabetic mothers, and in some GDM if they have other high risk factors like obesity. Mode of delivery, if it's a well-controlled gestational diabetes, we consider delivery between 39 to 40 weeks. If it's a poorly controlled or in diabetes requiring insulin, we consider delivery between 37 to 38 plus weeks. And cesarean section indication is mainly for obstetric indication, or if the estimated fetal weight is more than 4.5 kg, or in our population, if it is more than 3.5 kg, when you suspect a major cephalopelvic disproportion. Now, let me skip preterm labor. These are all not that important. Postpartum, very important is to screen these women for slipping into pre-gestational diabetes. So all these women will require a screening with a 75 grams GTT 6 to 12 weeks after delivery. And we all know that insulin resistance dramatically falls after delivery. We have to do a dose adjustment of insulin. And institution of lifestyle modifications is also very important in postpartum period. So breastfeeding, it is important to initiate in the early hours to avoid neonatal hypoglycemia, and also breastfeeding helps the mother to lose weight and reduces her risk of developing future diabetes. Care of the neonate, mostly the neonatologist will take care, but as we said, we have to screen for hypoglycemia at regular intervals, at least for the first 48 hours. And if it is a macrosomic baby, we need to do a detailed examinations for birth trauma and congenital anomalies in this baby, and also long-term follow-up for avoiding metabolic complications like diabetes. So education is the key. As I told, it is not only about the mother, but also the family and the society about awareness about what are all the risks of developing permanent diabetes, encouraging them to do moderate exercise of 30 minutes per day for 5 times a week to better sugar control and retarding the progression of insulin resistance. So the take-home message is encourage your diabetic mothers to have a planned pregnancy with a pre-pregnancy visit. Early screening and detection with an effective test will be able to identify the high-risk women and start intervention at an early stage. Lifestyle changes and appropriate pharmacotherapy will help us to maintain the sugar levels within the targets. And if you do an adequate surveillance, we'll be able to tackle most of the complications without adverse outcomes. And planning correct mode and timing of delivery will avoid a fetal-maternal trauma. And long-term surveillance in GDM mothers is imperative. Thank you very much.
Thank you, Madangi, for a very well wrapped up session with all the points. You didn't miss any of the point. Now I invite the chairpersons to give a few comments before the experts talk on GDM.
It
Thank
was
you,
a
sir.
very wonderful session, madam, and you have covered all the points. And we being an Asian population, we know type 1, type 2 diabetes are more prevalent, and we usually recommend that doing universal screening of all women, basically the pregnant women, should be recommended. Plus, I suggest being in reproductive medicine, I know there is more prevalence of PCOS women who are more prone for GDM. So, proper evaluation, prenatal counseling is must for all these women so that GDM and their prevention can be prevented in the pregnancy.
Yeah, ma'am, it is a very elaborated session. Pre-pregnancy counseling, and also before planning for next pregnancy, there should be known like these complications may be more in the next coming pregnancy. And also pre-pregnancy counseling is very, very important these days to lose the weight and plan pregnancy. Madam has very elaborated. Thank you, ma'am.
I think Kochumani ma'am is not there. I now request Seshasai sir, and then the last and final verdict by from Anjalakshmi ma'am. Seshasai sir, can you unmute, sir? Please unmute, sir.
Thank you, ma'am. Very nice presentation. Every statement is the milestone of in a GDM. And if everyone is practices, we will see 100% success rate in future. And we will go better safe motherhood. Really, it is one of the best class, best for postgraduates. And every point is important. And if they remember, if they work out, then we will have wonders of the results. Thank you, ma'am.
Thank you, sir. Ma'am, Anjalakshmi.
Yes, ma'am. First of all, congratulations, Madangi. Very beautiful presentation, and you have covered all the points up to the follow-up. So, as an expert, because they call me as an expert, I have 2 points to tell hither and there. Okay. The first thing is the definition cutoff. It is equal to or more than 140. So don't forget that. Even if they touch 140, they are GDM. Okay, one thing. And the next is early screening. Early screening, nowadays, no, we are want to screen at 8 weeks of gestation when the organogenesis is over. Okay, so that if it is anything abnormal, we can start treating the patient. So at 8 weeks, there are certain things physiologically happening. That is, fetal pancreas, it starts secreting insulin from 10 weeks onwards. It starts responding to the mother's glycemia from 10 weeks onwards. So why we want to check at 8 weeks? Because if it is anything abnormal, glucose is there, we'll have time to correct it before we reach the 10 weeks. So now we say screen at 8 weeks. That is at the earliest. And the two advantages are, one, if there is, because according to the definition of GDM, it is the abnormal glucose intolerance detected or occurring for the first time during pregnancy. Detected means that she may have heard it earlier also. So by doing the early screening and combining with the hemoglobin A1C, you will be able to differentiate between the established diabetes and the gestational diabetes. One. The second thing is, now what I am telling is that at 8 weeks, if there is a hyperglycemia, it induces fetal hyperinsulinism. And that fetal hyperinsulinism is a cause for all the adverse effects that are happening to the offspring. Okay. And next, another thing is, at 8 weeks, suppose if it is abnormal and you don't do the screening, and you are doing the screening around 12 weeks, what happens? The blood glucose of the mother is being utilized by the hyperinsulinic fetus, and when you do the test, mother will show a normal blood glucose level. Cheating. The cheating can occur, that is because of the fetal handling of maternal glucose. So this is a new understanding. Another thing is the fetal renal threshold is 110 milligrams. So when the mother's blood sugar is more than 110, it will pass on to the fetus, and there will be a glycosuria, which will give rise to the hyperamnias and macrosomia, all those things. So this is a currently coming up concept. Shortly, we will be doing the screening from 8 weeks onwards. So I just wanted to tell that. And another thing, in the treatment part, you said the GDM third trimester, you use the MLT and exercise for 1 week. Even that 1 week is very precious in a patient with a high risk cases. Okay, already there is a base for the macrosomia, and the mother has a preeclampsia vascular problem. You will have a very short time in the third trimester. So along with MLT exercise, you start the treatment, and the treatment is insulin. In the third trimester, if you are going to start, it is the insulin. Okay, and regarding the diet, carbohydrate, we always talk about a high carbohydrate diet in pregnancy, because when you look into the physiological changes in the metabolism of the mother, she quickly, if there is a lack of glucose, quickly she will go for a ketosis and ketogenesis. Okay, so for that, we should give them a high carbohydrate diet, but choose the allowable carbohydrate. That is a particular carbohydrate which is the complex carbohydrate having a low glycemic index. The glycemic index by means it is the rapidity at which the blood glucose level increases. Okay, so avoid food substances with having a high glycemic index. Choose always a food substances of the low glycemic index. Okay, and the wonder drug, you were mentioning about the insulin. Insulin is there with us for the past more than 100 years. Okay, now the wonder drug, we say is a metformin. Metformin, we can use it from consumption to confinement, and it has got, in addition to the reducing the insulin resistance, it has got many more effects, especially in the lipid metabolism, and the molecule, we call it as a wonder molecule or wonder drug. Next, then insulin degludec, you have mentioned, that's a newer drug which has been permitted to be used in the pregnancy. Okay, and one simple calculation I will tell for all the listeners. In the case of, because when you want to give insulin, you cannot calculate the dose of insulin according to a particular formula, because each individual, they have the intrinsic insulin, and also their sensitivity to insulin is different. So as a guide for the GDM patients, we always, when you want to start insulin, you start at the rate of 0.1 unit per kg body weight. Suppose she is weighing 60 kilograms, you start with 6 units. And usually in GDM, we always start the intermediate acting insulin. Now the degludec has some long acting insulin, which you can use it. And with your monitoring, then you can add on the short acting insulin according to the postprandial hyperglycemia. Okay, so that is that. Then, yes, anything? Then in the monitoring, it is when you are giving two insulin together, like a short acting and a long acting or intermediate acting insulin, and twice a day, it is always better you do the either 7-point testing or the 8-point testing. That is every meal, before and after, 2 hours after the meal, with the treatment. That is very important. And the hemoglobin A1C, very nicely you have said. And the continuous blood glucose monitoring, now people should be aware of that. The range, time in range and time below range and above range. That is very important. That means, no, the ideal blood sugar level should be between 80 to 120 milligram percent. When it is above, that should be less than 4%. No, the less than about 10 to 25%. But the ideal should be in range should be about 80%, which you have nicely elaborated on that. Very good. And then during the insulin resistance after delivery, what happens? That point has to be stressed, especially in a GDM women. Once the placenta comes out, once the factors for insulin resistance comes out, the insulin requirement falls. It precipitously falls and they will not require any insulin postpartum. And in diabetic type 1 and type 2, the requirement reduces and almost reaches the pre-conceptional level. Okay, that is the one. And now the postpartum screening, especially in a GDM patient, is very important because the GDM identifies the islet cell dysfunction. So those people, they have a islet cell dysfunction. So if you want to prevent the diabetes occurring, you can postpone the diabetes by doing an early screening. So what our textbook says is 6 to 12 weeks. What happens when you wait for 6 to 12 weeks? The priority of the mother, no changes to the baby. They never come for follow-up. So we have done studies in Chennai as well as in Delhi. We have done the 3rd day postpartum screening. And it's almost, it correlates with the 6 weeks value. So we are able to identify those people who become normal and those who have the IGT and also those who have the diabetes. We are able to identify, and by catching them when they are in the hospital, I think we will go a long way in the prevention of diabetes. Thank you for the opportunity given. Madangi, once again, congratulations. You are able to finish off all the points. I was wondering how we are going to talk all the points with your stipulated time. Thank you, ma'am.
Thank you,
Ma'am,
ma'am.
there is one question in the audience, ma'am. If
Yes,
you will
ma'am.
be able to please add a point on increasing insulin dose in mothers taking antenatal steroids, ma'am.
When they are on antenatal steroid, the requirement almost 1/3 to 50% it increases, and it lasts 3 days after the course of the steroid. So while you are giving steroid itself, it is better to admit the patient and monitor the blood sugar again in the same way before meal and after meal, and increase the dose of insulin to reach your target. Your target is, they said, Madangi said, fasting should be less than 90 and postprandial should be less than 120. So you can increase the dose. A rough calculation is 1 unit of insulin will reduce 10 milligram of blood sugar. Okay, so with that basis you can, but anyway, you have to titrate according to each patient. You have to tailor the dose. Okay, because you should know the sensitivity of them and then adjust the dosage. And you have to keep monitoring for another 3 days after the end of the steroid course and adjust the dose of insulin.
Thank you, madam. Thank you for such a crisp presentation and clarification of whatever Matangi was missing, and you are consistently telling that we have to do the sugar level early at 8.
Yes.
That is the take-home point of today's webinar, I suppose. And shall we move
And
on
also postpartum screening on
Is-
third postnatal day.
on the third day? Yes, madam. Both
Yes.
are take-home points. Yes, Madhu, can we move on to the next session?
Yes, ma'am.
Yeah, thank you,
For
Angela.
the session 2,
Gracious thanks, sir, and all the chairpersons for the first session. Now we will go on to the second session.
the second session is going to be the panel, the most awaited case-based discussion on managing GDM. So, ma'am, can I request you to introduce the chairpersons, Dr. Mumtaz Madam, Dr. Kanchan Madam, and Dr. Prachi Singh Madam, please?
Hi, Mumtaz is a very, very good friend of mine, and she is from Perindal Manna, Kerala, and she is now the president of Perindal Manna Society, and she is doing lots and lots of webinars, and she has come to all of our conferences too, and she has got so many awards from all Kerala conference, and Tampan Memorial Gold Medal, and Amendranath Dawn Prize for the best MCH paper.
That's okay, ma'am. That's okay. That's okay.
And AKCOG 19, and she's an oncology committee chairperson, and now she's the president of Kerala Perindal Manna Society. Mumtaz, welcome to this webinar.
Yeah.
Thank you.
Thank you. Thank you, ma'am.
Straight from a section. Very thank you.
Yeah, finished.
Yeah, Kanchan, she was the first one. When I called her, she said immediately yes. And she's the consultant gynecologist and the second Apollo Obstetric Gynec Society. And she has the first prize in AMOX 2008 for poster presentation. She's a junior consultant in Chennai. She has worked in Chennai in 2010 to, and so she must be knowing Tamil, I suppose. Practicing in Apollo since 12 years. Yeah, welcome, Kanchan. And Prachi Singh, MBBS from 1997, DGO DNB from Delhi, and Diploma IVF from Munich, and from Muzaffarpur. She is the IVF Center, Ashirvad IVF Center. She is a consultant, and also in Ayushman Endoscopy Center. He is zone coordinator for Endometrial Society of India and Imaging Science Committee FOXY. She was a East Zone coordinator from 17 to 21, and founder secretary of ISOBAB, and secretary MOGS, and past secretary of IMA, and now she's a secretary of Muzaffarpur OBG Society, and she has presented numerous papers in several conferences, and she has started the first IVF center in North Bihar in 2013, long time back, and innumerable successful pregnancy, and she has got a FOXY publication, Manual of Imaging in OG. Welcome, Prachi. Madhu?
Ma'am, can we have you obviously talk about our own dearest Professor Dr. Usha Rani, ma'am? Ma'am, thank you for making it today. I would love to honor ma'am through your words, ma'am. Vijaya, ma'am.
Yeah, madam is, you all know Usha Rani, ma'am. Who else won't know Usha Rani, ma'am? And very thankful to Usha because she has got high fever. In spite of that, now she has come only for us because she said readily she accepted, and she said, at least I'll take para and then join the panel like that. Thank you, Usha, for such a kind-hearted and encouraging us to do such webinars. And you all know she's from Ramachandra Medical College, and she is the program director of Gynae Endoscopy, which has started recently in Ramachandra University. And she's a professor of OBGYN, 33 years of teaching experience, and lots of presentations and publications. And she's a very, very good endoscopist. And she's got trained in Kiel's, Germany. And special field of interest is assisted reproduction, of course, operative endoscopy. Welcome, Usha, to take over the panel. Yeah, thank you, Usha.
Thank you so much, ma'am. It is in fact I thank Vijaya ma'am, Madhupriya, and Anjalakshi ma'am for organizing such a beautiful workshop today. And I'm sure all our people who are listening have really taken home a lot of messages. And we have our panelists today, Dr.
Should I introduce them on your behalf, ma'am?
Yeah, please. Thank you, madam.
Okay, ma'am. Madam has a very bad throat, so I would obviously try to help her with introduction of the 4 panelists. Dr. Ritu Hinduja, the Clinical Director of Cloud9 Fertility Mumbai. She's been a member of Managing Committee ISAR, member of Managing Committee Maharashtra Chapter ISAR. She is on the editorial board of Indian Accepted Edition of the Green Journal and the Human Reproduction Journal. She's received formal training in the field of reproductive medicine from the Institute Marquès, that is Barcelona, Spain, and also from Tel Aviv, Israel, and completed Masters in Reproductive Medicine from London. She's also received a diploma in reproductive medicine from Kiel University, Germany. A very good friend who had earlier been at Nova. She has been the clinical director at Nova, and now she is at Cloud9 Fertility. We welcome you, Dr. Ritu.
Thank you, Dr. Madhya.
And we have Dr. Priyanka. She's a consultant obstetrician and gynecologist and has presented papers and posters in various national and international conferences. She's a lifetime member of OXY and FOXY with special interest in infertility, high-risk pregnancy, gynae oncology, and minimal access surgery. And here I'm very, very happy and proud to say she is the daughter of my teacher, Dr. Uma ma'am, who is from West Mambalam. And welcome you, Dr. Priyanka. Next, we have Dr. Kavya Krishnakumar. Madam had begun her career as a junior consultant at KIMS Al-Shifa Hospital in Kerala, following which she had worked at Miyot Hospital in Chennai, and she has joined the founding team of Motherhood Chennai, and she is the resident consultant there, and she's playing a key role in establishing Motherhood as a premier center for women's health there. And she has a good obstetric expertise in high-risk obstetrics and laparoscopic surgery as well. Collaborates with several institutions dedicated to developing special children, and her family, her mom is also an obstetrician at Kerala. Her family has also contributed to establishing a center in Palakkad, Kerala, which supports children with special needs. Continue doing those great deeds, ma'am. Welcome on board. And we have Dr. Tendran, a good friend of mine, clinical lead and senior consultant, obstetrics and gynecology and minimal access gynecological surgery at Ma Kaveri Hospital by the Kaveri unit in Radial Road. And she has more than 2 decades of experience in OBGYN, interested in obstetrics and gynecology with high-risk obstetric interest. She did her undergraduation from MMC, post-graduation from JIPMER, and fellowship in minimal access gynae surgery. She had worked as an associate professor at SRM Medical College and Hospital for about 10 years before she joined Kaveri, and currently the clinical lead and senior consultant with areas of interest being high-risk obstetrics, advanced gynae endoscopy, and gynecology. Welcome on board, Dr. Tendran. Ma'am, over to you to go ahead with the panel, ma'am. Thank you so much.
Yes, please. Can we just get the screen shared?
Just a second, ma'am. I'm opening the document.
So as we get the screen sharing done, Madhu, are you going to share the screen, please?
Yes, ma'am. Sahiti is working on it, ma'am. She's
Yeah.
just going to share the screen. Yes.
Yeah. Meanwhile, I'll keep talking about the first case to save time.
Okay, ma'am.
It's a 34-year-old lady who presents at 8 weeks of gestation. She is a second gravida with a previous LSCS, and the last childbirth was 7 years ago. The first baby weight was around 3.8 kg. However, she was not established as a diabetic in her first pregnancy. The BMI right now is 13 with a family history of diabetes. So then, what will be the risk assessment of this lady? Can I ask Dr. Ritu, please?
Madam, could you go back one slide? Can I just look at the slide?
Yeah, please go back.
So, ma'am, if she's not developed any kind of diabetes in the first pregnancy, the risk would be a little lesser we don't put her in the high risk for developing diabetes in this, but with the age that will increase because she is 34 years of age, there is advanced maternal age, so we will be screening her, of course, and in this pregnancy we will be doing OGTT, that is like a normal for pregnancies that we do. Uh, we'll be doing an HbA1c as well to know whether there has been a chronic increased blood sugar levels. Besides that, of course, BMI is a contributing factor. So that and a family history also is a contributing factor. So we will kind of screen her in the high risk.
Yeah, definitely. Dr. Tendril, would you like to put her on low-dose aspirin also? I think so. Dr. Tendril is not online. And Dr. Priyanka?
Ma'am, I think they have some problem in the network and they are just off. They are trying to join, ma'am.
Yes,
Okay.
ma'am.
And Kavya, how are you? Yes, Kavya.
Priyanka is also there, ma'am.
Ma'am,
Kavya is also not in.
Priyanka?
Yes, ma'am.
Yeah, madam is asking, would you want to like to start aspirin?
Yes, ma'am. I would like to start aspirin, ma'am, because she has a high BMI of 33 kilograms per meter square. So I would like to start her on aspirin, low dose aspirin, ma'am.
So, supposing, say, her hemoglobin A1C comes as 10.1,
Yes, ma'am.
HbA1c at this early pregnancy comes as 10.1. How will you counsel and how would you advise her to proceed with this pregnancy?
Ma'am, I would like to do all the baseline investigations for the patient, ma'am. And since she's in first trimester, I would like to start her on. I would like to have a multidisciplinary approach by involving a diabetologist as well, ma'am, because she might need the insulin.
You definitely need insulin.
Yes,
Are we
ma'am, she will
worried
need.
about the congenital anomalies of the fetus?
Yes, ma'am, congenital anomalies. So I would like to. I would like to explain all the
I
high
give
risk
my
factors
2
to
bits
her, ma'am.
till someone else is joining in?
Ritu? Hello, Ritu?
Yes, Ritu, you wanted to add something?
Tendril?
Yes, madam.
Yeah.
This patient is at 8 weeks, first trimester. Going.
Okay, then I think I'll ask Anjalakshmi ma'am for her expert opinion and our ma'am, for anybody who's got a HbA1c 10 point odd, do we offer them the chances of having anomalies? Any kind of a termination should be discussed or not?
Madam is there, Anjalakshmi ma'am?
But I'm sorry to interrupt. I think most of the guidelines, they say if it is coming close to 10 HbA1c, we should discuss about the increased risk of anomalies and can be offered termination if the patient is willing.
Offering only, yeah.
Offering, not recommending, but it can be offered because the risk of anomalies is very high when it comes to 10, close to 22%.
Is that Dr. Madangi?
Yeah,
Yes,
yeah.
ma'am.
Yes, exactly. So this elevated HbA1c and their association with anomalies, we need to touch upon the role of a termination, at least put it on record that they have been counseled for something like that. But in future, if at all there are a large number of anomalies cropping up, then they would say you never counseled about it. If at all you had told us, we would have terminated, we would not have gone ahead. So that is one aspect. Can we have a change of slide?
Second case.
Yes. So what will be the, please go back no, by one slide. So the screening test, what is it that we are going to offer in this patient? The routine at 9 weeks, what are the other, who's online other than Ritu, Tendril, Priyanka and Kavya are not online.
Ma'am, I'm online only, ma'am.
Yeah, Priyanka. Then you can take the question.
Yes, ma'am.
Okay, then we go ahead with the second case. Here we've got a 32-year-old woman, a primary gravida who presenting at 9 weeks of gestation. Viability scan was done. CRL is corresponding. Fetal cardiac activity is good. During the early investigations, here they have done a fasting PP and a HbA1c. So to screen in the first trimester, do we do fasting PP and HbA1c, or do we always insist upon an OGCT? Is this also acceptable, FPS, BBBS and HbA1c? Yes, Dr. Tendril, you can take that question, please.
Yes, ma'am. We can do HbA1c and routinely. So here we have seen that
Two phones are on. That is why Tendril.
okay, madam. I will just switch off first.
Sorry.
Many time when we are trying to make this
Now it's better, ma'am. Okay.
pregnant ladies to take oral glucose, they tend to vomit a lot. And they come back and they say they are unable to
Yes.
complete the test. And so
In the first trimester, we usually can go for HbA1c, as Madhu ma'am says, because of vomiting, there can be OGDT can be difficult, so we can do a HbA1c, and this report shows that it's grossly abnormal. This case can be type 2 diabetes, undiagnosed type 2 diabetes.
Exactly.
And so here she's at 9 weeks. We have to check whether she's on folic acid tablets. We have to explain to her that there is high risk of the implications of this high value, and also there is risk of maternal and neonatal complications also during labor complications. So once we start folic acid, I will also do a joint, review, because this requires a multidisciplinary team approach where I will also involve a diabetologist and also the nutritionist to give her advice on the proper diet and also the exercise, and also start her on insulin. And also counsel her regarding explain to her the complications and make her take an informed decision about whether to continue the pregnancy or not. And if she agrees to continue, there should be a strict adherence to diet and also insulin and sugar control, plus or minus metformin, and NT scan and first trimester screening, pre-eclampsia screening, starting of aspirin from 12 weeks onwards has to be done 150 milligrams at bedtime. And following that, I can also advise an early anomaly scan for this patient, since there is a high risk of congenital anomalies, which is expected here. Mostly these anomalies could be cardiac also. So she also may require a proper anomaly scan between 20 weeks and 22 weeks, where we can do fetal echocardiography.
Usually, Gangadhar is a work. Can we go to the next slide, please? Yeah, so exactly like what Dr. Tendril was discussing. So other investigations are done, medications definitely insulin, and like how Anjalakshi ma'am had said, you can also give your insulin if you are in a place where you don't have a diabetologist. And how to schedule her Anthony, you will have to anticipate complications, is like how she has exactly told. Most important is to document it, please. in your OP chart. Most of us do not have an evidence of a documentation of the OP chart with us, and we have had a very bitter experiences in the past, wherein the OPK sheet wherein they sign and say they have accepted the risks and they're proceeding with the pregnancy, especially when your HbA1c is high, and a copy should be with us. So they have taken the decision by themselves, and we have counseled them about what exactly we had anticipated. We'll go to the next case, please. Next slide, please.
Sahiti, can you change the slide over, please?
We have
Thank
a 32-year-old, 32 weeks primary gravida who is diagnosed as a gestational diabetic. And right now she's on tablet metformin since 25 weeks of pregnancy. Monthly antenatal checkups are done, sugars are under control, and FPS is 92 and 126. Growth shows at 90th centile. Before we proceed with this, I was just wondering if ma'am is online, her experience with carbos
I am
compared
there.
to metformin.
Madam, Anjalakshi ma'am.
Yeah, ma.
Your
Carbos.
experience with the carbos.
See, but this patient is showing a macrosomia. Actually, the growth scan AC is the 90th percentile, 90th centile. So the baby is going for macrosomia. So we have to now institute insulin. Along with metformin, you give start insulin. And of course, it is very late now, 32 weeks. To certain extent, we can reduce the macrosomia. And Dr. Usharani wanted a carbo. Yes,
Instead of
Usharani?
metformin, madam, actually, I mean, not for this particular case, but I thought you will also speak about acarbose in your.
Yeah. So we
summary.
can use acarbose. Acarbose is supposed to be a glucose starch blocker, glucose blocker. It avoids the absorption of glucose. So, but the thing is, you have to use a small dose, 25 milligrams, 3 times a day. If the patient is against insulin, but tell her that already the changes for macrosomia has taken place, and to certain extent we can reduce it by adding acarbose. Even with insulin also, no, we cannot.
Yours, our president here, Monica Pathak, everyone of her contacts, Charulata
Some disturbance. Amma, unmute that person. Mute that person.
Okay.
Okay. Left to me, she's a primary gravida, 25 years. I will put her on insulin.
Insulin, yes, ma'am.
Right. Okay.
Yes. Can we have the next slide, please? Sahiti will have to shift here. Yes. So this is what we were discussed. And the other questions that we need to address here is, when are we planning to deliver her? And what are the complications? It's Dr. Priyanka will take the question.
Yes, ma'am.
Yes, do.
Ma'am, ideally, we can schedule our antenatal checkups once in 2 weeks, ma'am. And specific advice would be to check the movements of the baby and to check if the baby is moving adequately, and also to report in case of any query preterm labor signs like rupture of membranes or any labor pains, ma'am. And I would like to follow her up every once in 2 weeks, and I would like to keep checking her amniotic fluid index as well as her non-stress test, ma'am. And since patient is a GDM, though she is on well control, I would like to deliver her after 38 weeks. And again, delivery will also depend upon the pelvis assessment, if the baby is adequate to deliver vaginally or by C-section, ma'am. And precautions I would take would be to prevent PPH, because most common complication is PPH. And then in case if the pelvis is adequate for delivery, I would like to keep precautions ready for any kind of shoulder dystocia, ma'am. Complications anticipated again is shoulder dystocia, which is most common in case of vaginal delivery. Baby can also have respiratory distress post delivery because patient is diabetic. And I would also counsel her about need for instrumentation, ma'am, if any. And also, I will keep blood reserved, and I will start 2 IV lines for her when I'm delivering her to be ready to curtail any PPH if she has any.
Can I have our chairpersons to make a comment on this case, please, or add on to their to the learning? Dr. Kanchan, Dr. Mumtaz, and Dr. Prachi Singh.
So,
Are they online?
They are there.
We're requesting the chairpersons to add their views
the,
about this case.
Dr.
please.
Anjalakshi here,
Yes, ma'am.
Usharani.
Yes, ma'am.
This patient, because she is going for the macrosomia,
Yes,
and
ma'am.
we can anticipate a preterm delivery also. So
Yes.
there is a role for a steroid prophylaxis.
Hmm.
Okay, she is 32 weeks now.
Yes.
Okay.
Hmm.
And when you start on steroid, close follow up with the blood sugar. That is very important for
Hmm.
5 days
Hmm.
before you come back to her usual requirement.
Hmm.
And delivery should be planned in a tertiary center with a senior obstetrician by the side with a neonatologist.
Hmm.
Because as she said, we can anticipate even when the baby weight is normal, there is an increased chance for shoulder dystocia in a GDM baby because of the increased fetal fatness.
Yes.
Okay, so they have to anticipate that, and a senior person should be there.
Hmm.
And of course, cesarean is only for the obstetric indications.
Hmm. Hmm.
The complication anticipated is like preterm delivery, shoulder dystocia.
Hmm.
Since the blood sugar, actually, though you have said 92 and 126,
Hmm.
there is, I think, in between there may be some fluctuations
Yes, ma'am.
which we are not aware. So even sudden intra-infant death is possible. Though it appears as though it's well controlled, the GDM.
Hmm.
Sudden IUD possibilities are there.
Yes, ma'am.
Okay.
Can we go on to the next slide, please? Here we have a 33-year-old primary gravida. She was diagnosed with GDM at 20 weeks itself. She's on tablet metformin, TDS, and insulin, 16 units and 8 units. Most of the time we give her mixed at 50-50. Now at 35 weeks of gestation with a fasting of 108 and PPA is 136. The growth scan says that the estimated fetal weight is at 17th centile. Can our panelists take it, please?
So I'll take that. This patient is primary gravida 20 weeks. She's already on metformin and high dose of insulin, and she's now at 35 weeks. So the fasting sugar is slightly, the fasting and postprandial shows that it's slightly on the higher side. And one thing which is not so typical is the 17th centile estimated fetal weight. Usually with such high sugars, we expect macrosomia or LGA babies. But here we also have to rule out an added preeclampsia component. So maybe this case will also require a Doppler and close follow-up and to check whether the baby is going in for IUGR. So other investigations like to rule out preeclampsia, the urine protein, and also the liver function test, complete blood count, platelet, and all that renal function tests all can be done. And close monitoring of blood BP monitoring can also be advised to her.
What is the role of Dr. Mantangi was saying, if there is any kind of a reduction in the estimated centiles, do we continue the metformin or should we stop it?
So here,
you continue the metformin and deliver her at the completion of 37 weeks, Usha. That is
37. Yeah.
Because she had told in her presentation that when there is an IUGR, metformin is not to be given and insulin is better, is what she was trying to tell.
True.
Yeah. So What are the complications anticipated? The same, I'm sure, because of if there is an IUGR, we have.
So if there is an IUGR, then there can be intrauterine demise, fetal demise can happen. So prematurity is one thing, and neonatal problems, complications can happen. So
Hypoglycemia.
with abnormal Doppler, if there is abnormal Doppler, we have to deliver then and there. So here also there is a role of corticosteroids and natal corticosteroids. We can admit the patient and also we can give steroids under and strict blood sugar monitoring can be done, and prepare her for delivery at 37 completed weeks.
Hello.
Can we go ahead? Yes, Dr. Prach, please.
Yes. Good evening, everybody.
Good evening.
It was at 20 weeks, the fetal weight was less 17 centile. I couldn't get that.
Right now, 35.
Okay, it is 35 weeks now.
35 weeks.
Right. Yeah, okay.
Late onset.
So again, since it was early onset, it could be type 2, undiagnosed type 2 diabetes also.
Yes, yes. And pre-existing hypertension also might be there. So we have to, as has been said, that has to be
ruled out. Exactly. And close monitoring with the Dopplers should be a good idea in order to take her, and with a good fetal movement count probably. That should be fine. We go on to the last case of the today's session. Yes. It's a 22-year-old primary gravid with a normal nuchal translucency and anomaly scans and uneventful antenatal checkups. At 25 weeks, she brings an OGTT. This is a 75 gram fasting, 1 hour and 2 hour. So what would be the next step to be taken ahead?
Ranchi, do you want to take that?
She's a primary gravida, normal NT and anomaly scans. Presents at 25 weeks OGTT. Yeah, so she's 25 weeks and we have some time. So after doing a MNT, and if she probably because her sugars are quite high, 1 hour is 190. So if she responds to MNT well and good, otherwise her with see how she responds. And depending on how her response is, then I would like to start insulin and monitor her very frequently to see whether her blood sugars stabilize. And because the anomaly scans and NT is normal, so we have ruled out any anomalies. The only thing now is that we have to monitor her blood sugar and see that her growth is not a problem with the increased blood sugar.
Excellent. No, that was a good, concise answer for that lady. And this brings us to next slide, please, to the end of this case-based scenario. I think we wrapped up what Dr. Matanki has discussed in such detail, and Anjalakshi Madam's wisdom, and all our panelists' active interaction with trying to get on to this little cases, which we are all doing definitely in our routine practice, but we need to hone our skills, talk to each other to make sure that we are doing the right thing, and also to protect ourselves medically equally. So once again, I would say documentation, like how Anjalakshi Madam said, do an OGCT early and also do a postpartum screening on the 3rd day. But along with this, please kindly maintain an OP documentation with the consultants.
Usha Rani, in the last case, no, I just want to add one point.
Yes, ma'am.
She said the NT scan and anomaly scan has ruled out all the anomalies.
That's not necessary.
Not so in diabetes because it can affect all the systems. Okay,
Yes.
and the gastrointestinal anomalies you cannot just make out in the 2nd trimester scan. You have to keep looking for it even in the 3rd trimester.
That's
Yes,
true.
That is the exam point of view. Okay, right.
Yes, yes.
Okay.
That is true. Thank you, madam.
Thank you.
We always have surprises with an anal imperforate
Yeah,
anal.
yeah.
It's very difficult anomaly to
Right.
pick up. Yes, ma'am.
Yeah.
Yes.
Because of the-
See, for the postpartum, there's a question. For the postpartum third day, whether to do GTT or OGCT. You can do OGCT itself because that the patient is used to that, the health workers are familiar with that. So it is easier to do also. So there is no need to do a GTT. If you do GTT, there is no harm, but there is no need to do it. You can do either this one or that. Okay?
Oh, that's a wonderful point taken.
Yeah.
We thank our panelists and our moderator and our chairpersons for the session. Thank you, Vijaya ma'am.
Thank
Yeah.
you.
Thank
Thank
you,
you for
Madhuriya.
having me in this nice session. Thank you very much, Dr. Vijaya and Dr. Madhu.
Thank you, Prachi, for be actively participating. We really appreciate that. I asked Madhu to give a proper vote of thanks.
Thank you one and all for the opportunity, first of all to me, and then Vijaya ma'am, we would love you to become one of the chairperson in the committee. We would love to support you for doing all these education related activities. And to the experts, Sesha Sai sir and Anjalakshi ma'am, thank you so much for accepting to be the expert panel and give us your wisdom. And to the speaker, Dr. Madangi Rajagopal ma'am, thank you so much for giving your time, giving your expertise, what you have been doing so far in the regular practice, and putting us all through a very short, memorable class today. Thank you so much, madam. And Professor Dr. Usha Rani ma'am, thank you very much for accepting despite your ill health. And we are very, very happy that we had you. And all the very best and get well soon to you. And to all the panelists, thank you very much for participating actively. And to the esteemed chairpersons of both the sessions, thank you very much for being very active throughout the sessions and helping us go through the whole session successfully. Thank you for all the delegates who have taken time to participate and having been interactive on the chats. Thank you so much, Manan.
So happy we have touched more than 100.
There was one question,
And
ma,
expected,
the chat box, whether to do the GTT or fasting PP blood sugar at 6 weeks.
Yes, ma'am.
Okay, we are shifting the 6 weeks to the third postnatal day 1. Another thing is, if you are going to do when you missed on the third day, you are going to do on the 6th week. In between, you will be monitoring the blood sugar, fasting and PP. If they are normal, you do a GTT to reclassify whether she is a true GDM or she has IGT or a type 2 diabetes or diabetes. Okay. If the blood sugars are abnormal, then you are going to follow up with only fasting PP.
Madam, come again, madam. Come
After delivery, you will be repeating the fasting and PP blood sugar once in 15 days like that. Okay. So if it is normal, you do the GTT at 6 weeks. The question was asked whether GTT or fasting PP blood sugar. If it is abnormal, even in the IGT range, then you do only the fasting PP blood sugar and confirm whether it's IGT or a diabetic. Okay.
Okay, madam. Okay. This postprandial is 1 hour or 2 hours? There is one
2 hours.
question.
2 hours all. See, the 1 hour is only for our convenience. Okay. So it is always better to do 2 hours.
Always 75 gram, 2 hours.
Oh, yes.
Yes, ma'am. Thank you. Thank you so much. Thank you, Sagiti, for giving us the platform. And thank you, Madhu, for staying throughout.
Thank you, Vijaya, and your team, Madhu Priya.
Yes, madam. Yes, madam. Thank you so much, madam, for staying. Thank you all. Good night.
Good night. Energy, Dr. Usha Raniki. No problem.